Good morning, everybody. Can everybody hear me okay? Okay, perfect. Thank you so much. Well, good morning and welcome to the 41st North Carolina Institute of Medicine annual meeting. I understand that there is, as is usually the case in the Triangle, very bad traffic this morning. So we're expecting folks to continue to trickle in. Please make room at your tables. Please welcome our additional friends who will be joining us as they're able. So my name is Michelle Reese. I'm the president and CEO of the North Carolina Institute of Medicine. I have been serving in this role since April of this year, after also serving as interim president and CEO since about January, when my predecessor, Kathy Colville, stepped away. This has been a time of very exciting transition, and in a few minutes, we're going to take you through some of the work that our team and our partners have done in the past year, all in the service of better health for North Carolinians. I'm here with Adam Scholar, who is our board chair at NCIOM and who is president and CEO of the North Carolina Healthcare Facilities Association. Before we get into our program, I do want to personally thank each one of you today for choosing to spend your time with us today. I hope you will have a fulfilling and productive day, learning from one another and discussing solutions to the issues of long-term services and supports in our state. So before we go further, we do want to take a moment to acknowledge the stress and the pain that many in our state are experiencing due to the impacts of Hurricane Helene. I know that impact is felt directly by many in this room, whether that is on a personal level or on a professional level as you're working on response. We are grateful to the folks at the North Carolina Department of Health and Human Services, the Division of Public Health, the Department of Environmental Quality, and the many other state agencies, community organizations, philanthropy, schools, providers who are working tirelessly on recovery efforts. We know that this recovery has been and will continue to be multifaceted and will last well into the future. And we are in the process at NCIOM of identifying opportunities to apply our research and convening resources and skills to be a part of that work and recovery as well. We'd also like to take a moment to do a land acknowledgement, as November is National Native American Heritage Month, and our state has one of the largest populations of Native Americans in the country. Last year, Dr. Cherry Beasley of UNC Pembroke did us the honor of developing some language to acknowledge the indigenous residents of the land where we meet today. North Carolina State University and the city of Raleigh sit in the upper Neuse River Basin that includes the traditional lands of the Tuscarora, Cherubra, and various Tutelo, Saponi, and Siouan-speaking people. Today, we acknowledge their displacement, dispossession, and continued presence in the Halawa Saponi, Saponi, and Occaneechi Band tribal nations. Thank you to Dr. Beasley for this language. Today also happens to be National Rural Health Day, and this month is also National Family Caregivers Month. So this is a great time to be having the discussions that we're having today about long-term services and supports, particularly in our rural areas of our state, and particularly as we're thinking about the issues surrounding family caregivers. So now a little bit about the North Carolina Institute of Medicine. I see a lot of familiar faces here today, but I know that there's a lot of people who might be new to our organization, new to our work, new to our annual meeting. So we did want to take a few minutes and tell you a little bit more about what we do and who we are. So we are an independent nonprofit organization committed to better health for all North Carolinians. We were chartered by the North Carolina General Assembly in 1983. And since then, we have worked to provide nonpartisan information and opportunities to all those who impact the health of our state. We do this through convening people with diverse perspectives and experiences to build consensus on issues of relevance to the health of North Carolina's population and to make policy recommendations for things that will improve these challenges. We do this convening in many different ways, including large task forces, smaller advisory groups and work groups, virtual and in-person events, and conferences like today's annual meeting. Now I'm going to turn things over to Adam for just a moment. Adam has served on our board of directors since 2020 and has been chair of the board since this past January.
Thank you, Michelle. It's great to be here today representing the board of directors of the North Carolina Institute of Medicine. The work you will hear about shortly is a true reflection of our organization's mission of building consensus for evidence-based solutions to our hardest health problems. You'll see that commitment in the work of our recent task forces that develop policy recommendations you'll find in the materials you have in your welcome bags. You'll see it in the curriculum of the Legislative Health Policy Fellows program and in the NCIOM's commitment to acting as a foundational partner to statewide initiatives like the new Center on the Workforce for Health. I am partial to the topic of today's annual meeting, which I will talk about a bit more in a few minutes. For now, I would like to share my heartfelt appreciation for the dedication of those who planned this meeting and put together an agenda that was developed with input from thought partners from many sectors across the state. Nonpartisan, solutions-focused events like this are a keystone of the work of the NCIOM.
Thank you, Adam. So this year has been one of great change and evolution for our organization. At the end of 2023, the Task Force on Healthy Aging published recommendations and strategies focused on improving social connections, falls prevention, food and nutrition security, and mobility among aging North Carolinians. NCIOM staff continues to provide presentations on these recommendations when requested, and the Division of Aging recently published the state's multi-sector plan for aging, all ages, all stages, which used the work of the task force as a basis for much of the recommendations in that plan. We will hear more about that later this afternoon. This spring, we completed not one, but 2 additional task forces and published reports detailing their work and presenting policy recommendations for improved health in our state. The Oral Health Transformation Task Force made recommendations to state policymakers focused on the delivery of equitable, accessible, integrated, and high-quality oral health care. And the Task Force on the Future of the Nursing Workforce presented evidence-based recommendations focused on addressing our state's critical shortage of nurses and ensuring that they feel prepared and supported to practice. We'll also talk more about these projects later this afternoon. Also this spring, we were happy to recognize 22 members of the North Carolina House and Senate for their participation in our 2024 Legislative Health Policy Fellows Program. This program, which we established in 2018, provides data, resources, and facilitated discussion to help legislators learn more about healthcare, health policy, and the key health challenges in our state. This cohort was the 4th since 2018 and included 10 Democrats and 12 Republicans representing districts across the state. To date, more than 75 members of the North Carolina General Assembly have completed this program. One thing we were very excited about this year was that I think 3 of these folks had done the program before in 2018 or 2019, and they said the context has changed. There's a lot more to learn, so they came back again, which we were very pleased to see that they found it that valuable. A session for legislative aides will begin in January, and we are also continuing a webinar series for alumni of the program, bringing expert speakers and Q&A to legislators on topics of their choosing. We also held in July an opioid research convening in partnership with the North Carolina Association of County Commissioners and with help from the Department of Health and Human Services and the UNC Injury Prevention Research Center. This event brought together people with lived and living experience, leaders of local and state organizations, and other interested parties to develop research questions to guide opioid response efforts in North Carolina. We also recently completed the facilitation of a task force update committee working to update recommendations from our 2015 Essentials for Childhood Task Force. New recommendations and update to the previous strategies are currently being finalized, and a report on this work will be published in February. We have also been working with El Futuro, which is a behavioral health services provider in Durham, to develop an immigrant mental health policy network. We recently completed a landscape analysis identifying key mental health needs, barriers to mental health care, and gaps in data. This analysis was primarily informed through interviews and focus groups with people with lived experience and service providers, and we would like to thank our partners in this work who were invaluable in helping us frame and facilitate these discussions in a culturally competent and meaningful way. The long-term goal of this policy network will be to develop consensus recommendations for policy and system change to improve mental health outcomes for immigrants across our state. We also continue to work on maternal health in partnership with DHHS, with convenings and publications aimed at guiding, developing, and advancing the state's perinatal health strategic plan. As part of this ongoing work, we've convened a series of action teams, developing considerations for the state on the integration of maternal levels of care and neonatal levels of care within birthing facilities. We also have an action team focused on equity in practice that summarizes recommendations to improve access to perinatal resources for incarcerated people. And we also have a doula action team, which has developed recommendations to the state to support successful adoption of doula services as a Medicaid benefit. We also published the North Carolina Medical Journal, and we published 6 issues of this journal in 2024, focused on heart disease, cancer, and stroke in North Carolina's changing public payer landscape, interprofessional care and practice, artificial intelligence in health and healthcare, substance use in North Carolina, and transforming oral health in North Carolina. Several of these issues were available at the registration desk. Please feel free to pick up a copy if you'd like, or to join our mailing list to get virtual copies of this as well. Beginning in January, we will actually be stopping print publication of the journal on a 6 times a year basis and shift the journal's focus to more original research, while the health policy analysis and interviews that we feature will continue to be distributed in a twice monthly newsletter. This decision was made as a result of key informant interviews and focus groups with current and potential readers and contributors. And lastly, I did want to mention that after 12 years as editor-in-chief of the journal, Dr. Peter Morris has stepped down and has become editor emeritus, and Dr. Ronnie Bell, who has been a co-scientific editor of the journal for 5 years, has stepped into that editor-in-chief role. So thank you to both Dr. Morris and Dr. Bell for their service to the journal. And lastly, we couldn't have done most of this work without a lot of synergies with what we have affectionately come to call our Evolve project. Last year, with support and funding from the Duke Endowment, we've been working as a team to strategically plan for sustainable improvements in our work in these 5 areas: communication, evaluation, legislative relationships, task force redesign, and meaningful engagement. We spent some of this time working alongside the South Carolina Institute of Medicine and Public Health, including several productive and fun in-person retreats. And we have a couple of our partners in that work from South Carolina here with us today as well. Throughout this initiative, we've identified learnings, best practices, and strategic priorities for change. And we are focusing this year on these improvements in our communication strategies and our evaluation strategies to better understand the impact of our work. So as you can see, we have been busy. We are not slowing down. We are currently in the planning phase of a task force on veterans health that will start next year. We will approach this task force a little bit differently with the learnings from Evolve in mind. It will be a 24-month task force, beginning with 6 months of learning, site visits, focus groups, interviews with persons with lived experience to ensure that we are meaningfully engaging with this subject and the people most impacted as we convene and develop policy recommendations. We are also working with North Carolina AHEC and the Center on the Workforce for Health to plan a series of workshops on the direct care workforce in early 2025. Please join us this afternoon in our closing session, where we will tell you a little bit more about these new projects and their relationship to the conversations that we're going to be having here today. So with that, I'm going to turn it back to Adam for a few minutes to tell us a little bit more about NCIOM governance and our topic of the day.
Thank you, Michelle. And just to acknowledge all of the work, this is not on the script, but all of the work that Michelle just went through is done by roughly half the people in that picture. The other half are from South Carolina, so it's pretty incredible, and just would like to take just a moment to applaud our staff for all the outstanding work they do. So with that, I think it goes without saying, but all this work wouldn't be possible if not for the organizations that share our mission. We would like to thank those organizations for the support, guidance, and partnership they offer the NCIOM year after year. Let's see. Project sponsors and anchor supporters for the 2023-2024 timeframe are listed here, right there. So please, if you represent one of these organizations or see someone who does, thank you, thank them. We couldn't do it without your support. As chair of the NCIOM board, I also want to recognize and thank our 21 board members who come from all parts of the state and represent healthcare, public health, research, administration, education, and business sectors. If you are on the Institute of Medicine board, would you please raise your hand just so we can recognize you? All right, thank you. Let's give this group a round. This year, we welcomed 3 new members to our board: Trish Marcus, who is a partner with Nelson Mullins, Riley, and Scarborough; Patricia Pfeiffer, president of Wayne Community College; and Frank Courts, who is a pediatric dentist and chair of the North Carolina Dental Society Council on Oral Health and Prevention. We also added 8 new folks to the North Carolina Institute of Medicine membership. The board of directors appoints these members, who participate in task forces, work groups, publications, conferences, and more, and provide a network of experts to inform and help us disseminate our work. It is gratifying to see the results of this support for the work of the NCIOM on days like today. The full listing of the board of directors is there on the slide, and then the 8 new members of the Institute of Medicine this year are on the slide, on both sides of me. The purpose of today's 2024 NCIOM annual meeting is to focus on ideas and innovations in long-term services and supports in our state as the demographics of North Carolina change and our needs and opportunities change along with them. As the head of the North Carolina Healthcare Facilities Association, which is an organization that represents 400 nursing homes across the state, I wake up every day thinking about the challenges North Carolina faces in caring for our aging population. But as you'll hear over the next several hours, this is an issue that impacts us all. And it will take all of us working together to address and overcome the obstacles that we face. Today, our nursing homes care for more than 38,000 residents, and those numbers are going to grow dramatically in the years to come. As you'll hear, the number of North Carolina residents over age 65 will increase by 50% over the next 2 decades, and the number of North Carolinians age 85 and over will more than double over that time period. And with that, we'll have more and more people who need hands-on care, whether they get that at home, in a nursing home, or somewhere else. The challenge we face is that even today, we don't have enough people in the long-term care workforce to meet the demand. Nursing homes and home health agencies are still down roughly 5% of their workforce since early 2020, and assisted living facilities have lost roughly 10% of their workforce since the onset of the COVID-19 pandemic. Long-term care providers, regardless of setting, are struggling to recruit and retain the workers who provide the compassionate and often difficult work of caring for those who are in need. During the course of the day, you'll hear about how we are working to grow our long-term care workforce, improve the delivery of care, shape policy, and secure adequate investments to provide the care North Carolinians deserve. The good news is that you'll see that we have a very talented and dedicated group of people across the state who have been studying these issues and working on solutions. North Carolina DHHS Secretary Cody Kinsley is not able to join us today, but he sent some brief remarks about the importance of continuing to study and develop solutions to long-term services and supports issues, which we will watch now.
Hi, I'm Cody Kinsley, North Carolina Secretary of Health and Human Services.
We're going to watch it in a minute, I promise. Hang on.
I'm Cody Kinsley, North Carolina.
Or we're not. Hang on a second. Sorry.
We're going to watch it just 1 minute more.
It showed up before. Ah, there we go.
And then that should... Do you want me to go ahead and start?
Yeah, that's fine.
Human Services. I want to welcome everyone to the North Carolina Institute of Medicine's 41st annual meeting. I know that this conversation will focus on issues around aging. And this is an issue that I'm particularly concerned about as the Secretary. As we look at North Carolina's demographics, we have to ask the question about how we care for folks as they're aging in our state. North Carolina is rapidly growing. And we know over the next several years that a disproportionate number of folks in our communities are going to be older. And yet at the same time, we don't see that growing demography among our younger individuals. Models of care around aging that look like facility-based care, in-home care, are going to become increasingly more challenged. Getting upstream to make sure that folks can age well starts with combating chronic disease. It invests in issues of prevention, and it helps make sure folks can tackle loneliness, to live well in their homes, in their communities, and feel supported at any stage of life. This is why Governor Cooper charged us all to come up with an any age and any stage, all ages and all stages plan for North Carolina. This is not specific to the Department of Health and Human Services, but it looks at transportation and other areas of our communities to make sure we can make North Carolina a great place to live at any stage and any age. Thank you for your work. Thank you for being together. And I'm so happy that you'll be together at this conference.
Great. All right, I'm going to find my slides again. 1 second. And there we go. All right, so before we turn it over to our keynote speaker today, I just want to provide a brief agenda and logistics overview. All of this is in your program, so I'll just hit the highlights. In just a moment, we will hear from our keynote speaker, Robert Espinoza of the National Skills Coalition. Our plenary panel about ensuring sustainability will begin at 10, followed by a break and then the morning breakout sessions. An invitation-only session for legislative members and staff of the legislature will take place at the same time as those breakout sessions. Lunch will begin at 12:15. We hope you will take some time to network during lunch, but please be sure to meet back here at 12:50 to hear from some of our Western North Carolina colleagues about their work on Helene recovery. We will have a break after lunch, and then afternoon breakout sessions will begin promptly at 1:30, and the closing session will begin at 2:45 when we will hear about North Carolina's multi-sector plan for aging, all ages, all stages, from Deputy Director of the Division of Aging, Jill Simmerman Lawrence, and Mary Bethel, Chair of the North Carolina Coalition on Aging. We will wrap up at 3:30 with a brief discussion about what's next for the NCIOM and closing remarks. There is a map of facilities in your program. The meeting rooms that we will be using for breakout sessions are circled in red here, and they are basically straight out this door and down the hallway, so fairly easy to find that way. Today, we will also be using Mentimeter to receive your questions for our speakers. You don't need to download anything. We didn't want anybody to have to put a new app on their phone. Each session will have a QR code that will take you directly to the website to input your questions there, and then our facilitators will be able to bring those to our speakers. Before we begin with our keynote speaker, I'd like to recognize the sponsors who have made this day possible. Our gold sponsor, the North Carolina Healthcare Facilities Association, and our silver sponsors, Health Management Associates, WellCare, and Carolina Complete Health. So with that, I am very pleased to introduce our day's keynote speaker, Robert Espinoza. A national expert in workforce, aging, and caregiving issues for more than 25 years, Robert is currently the CEO at the National Skills Coalition, which fights for state and federal policies that promote inclusive, high-quality skills training so that workers across industries access a better life and local businesses see sustained growth. Prior to this role, he served as the Executive Vice President of Policy at PHI, where he oversaw its acclaimed think tank on the direct care workforce for over a decade. In addition, Robert is a non-resident senior fellow at the Brookings Institution and sits on the board of directors for the National Academy of Social Insurance, the Frameworks Institute, and the American Society on Aging, where he serves as board chair. In 2020, Robert was selected for the inaugural Care 100 list, recognizing him as one of the most forward-thinking individuals reshaping the landscape of caregiving in America. And in 2021, he testified before Congress on the profound need to transform direct care jobs. Since 2023, he has hosted A Question of Care, an award-winning podcast exploring the many challenges facing our country's caregiving system. If you have questions for Robert that occur to you as he's speaking, please use this QR code on the screen to submit them. Just point your phone's camera at the square and it will send you to the website for question submissions. So Robert, I'll turn it to you.
Good morning, everyone. It's good to see all of you. Before I start, I want to offer an enormous thank you to Michelle and to Adam, and thank you to the North Carolina Institute of Medicine for inviting me to speak, but also for centering this really critical topic of direct care workforce issues, and specifically how it relates to the long-term care system and to the healthcare system more broadly. I also want to thank all of you. I know that you've taken time out of your days, out of your busy schedules to join us this morning and hopefully throughout the day. And thank you for all the work that you're doing in this really beautiful state. I want to start with a personal story. And it's meant to frame my remarks on the workforce. It's also meant to help illuminate the ways in which workers and healthcare and long-term care interact, or in many cases don't always interact in the best way possible. On February 4th, 2016, I was a resident in Brooklyn, New York, in the small neighborhood of Sunset Park, Brooklyn, for those of you who know the region. I woke up in my 490 square foot studio apartment, true story. And I woke up and went to the gym, and I expected it to be a normal day. After the gym, it was 20 degrees outside. It was a chilly day. I took a cab home, and that's the last memory I have until I woke up a week later at this hospital. It turns out I would find later that around 5 p.m. that evening, my widowmaker's valve, or my left anterior descending artery, for any physicians in the room, had clogged and I had gone into cardiac arrest. I would learn that I fell face first on the sidewalk into a snow pile. My heart stopped for a total of 45 minutes. And the only reason I was kept alive and cognitively functioning is that 2 EMTs happened to be having coffee across the street. They ran across the street, gave me CPR until 45 minutes later, where I was able to be rushed into surgery. I was placed in a medically induced coma for a week. I was told at the time that I had a 6% chance of survival. It took 6 tries to restart my heart. And 2 weeks later, I was discharged to a rehab center. And 2 weeks later, I was discharged home. A few days later, a home care assessor from a New York City home care agency came and visited me, and they assessed my situation. The only way for me to let them into our building, I lived in a brownstone and I was on the 2nd floor, was to descend the stairs very slowly and open the door. And when the assessor saw this, he told me in a very direct way that I had most likely disqualified myself from any home health care support because he had clients all around the city who hadn't left their bed in days, and there was a shortage of workers. I qualified, if I wanted to, for a 15-minute visit once a week where they would check my temperature, my vitals. I was put on 15 medications, and within 5 weeks, I descended into a state of delirium, and I was back into the hospital, in and out for the remainder of the year. In fact, the total cost, healthcare costs, covered mostly by my insurance, gratefully, was about $1.5 million that year. This story still haunts me. It haunts me that at the time, I was the executive vice president of policy at PHI in the Bronx, a national-based organization. I had been in the city for 6 years. I worked at a senior center that was also a national model on innovation and senior services. And yet, despite all my relationships, despite everything I knew, my social and political capital, if we want to call it, none of that protected me in that moment. And it haunted me. What is it about our country's caregiving system, about the workforce in particular, that is making care so inaccessible in some of our gravest moments? And that's what I want to guide us through this morning. Just for level setting, I want to point out a few statistics on direct care workers, and many of you might know this, but this could be a good refresher. By definition, direct care workers support older adults, people with disabilities, and people with chronic conditions in a wide range of settings. They help with what are called activities of daily living, for the most part, bathing, dressing, eating. Some of them help with medication adherence. They help with running errands, with other tasks, with companionship. Many direct care workers offer respite and support to family caregivers so that they themselves can take a break or can remain employed. And by occupation, they include home health aides, personal care aides, and nursing assistants, though the titles do vary by state, and I recognize that complexity. And they work in our private homes. They work in residential care environments like assisted living, and they work in nursing homes. Data from PHI shows that there are about 5.1 million direct care workers in the US. There is data on North Carolina in one of the handouts that is at your table. The vast majority of direct care workers are women. About 66% are Black, Latinx, or other people of color, and 28% are age 55 and older. 1 in 10 is age 65 and older. One of my former colleagues used to say that many workers, direct care workers, rely on Medicaid and other kinds of public benefits to survive, even though they're working part-time and full-time schedules. And so we're talking in many ways about a Medicaid economy. Their jobs are paid for as a public system, primarily by Medicaid, and they themselves access Medicaid in order to survive. I would say it's an older Medicaid economy because in many instances, we're talking about older people supporting older people, and that's a trend that we'll continue seeing. I mention this also for 2 reasons. One is that these are populations that historically have had a very different employment and education trajectory, often facing distinct barriers that make that trajectory just very different and often rooted in profound hardship. But when we think about recruitment and recruiting new labor pools to fill job openings, we should also think about the inverse of these statistics, right? What are we doing as a sector, for example, to recruit more men into direct care to fill jobs, right? That's a question that's relevant, I think, for all of us. Direct care workers are incredibly valuable to older adults, to people with disabilities, and to family caregivers. And I think many of us who have benefited from a direct care worker can attest to that. My aunt is a hospice care worker in Southern Colorado, and she tells stories about clients and family members who, after the person passes away for years, would send her holiday cards and presents and visit her because they found her support so valuable in a time that is so grave and sacred. And I think a lot of us can attest to the ways in which, when we have access to an affordable and accessible, highly trained direct care worker, what an incredible and profound impact it has. But it's not just impactful for people, it's impact for society at large. It's a shared prosperity model when we think about it. Direct care workers are essential to the economy. As taxpayers and as public spenders, they contribute in those ways. I mentioned that they help family caregivers with respite and support, who they themselves as family caregivers can then remain employed and contribute to the economy. There are a number of demonstration projects that have shown that they can help with transitions from hospitals to a rehab center or to home that are often really precarious, and if they're not handled properly, can lead to preventable rehospitalizations, which are costly in a multitude of ways, right? We also know that when workers are better trained on observation skills, on supporting people in their homes, they prevent accidents and they prevent hospitalizations and visits to the ER and so much more. We also know, Genworth, of course, many of you are familiar with this, does an annual study that shows the annual median cost for different types of long-term care settings. It can range anywhere from $40,000 to $60,000 for home care, depending on what you seek, all the way up to $140,000 for a semi-private or a private room in a skilled nursing facility. And those costs increase by year. They increased from 1% to 10% in the most recent study by Genworth. And yet a good, well-supported home care system can actually support more costly institutionalized care. And the more we invest in home and community-based services, the more we ensure that nursing homes then become the resort for people who really need the 24-hour skilled care, and for most people who prefer to age in their homes and communities, that they themselves have that support as well. Direct support professionals are a segment of the home care workforce who support people with intellectual and developmental disabilities. And they offer a multitude of benefits for people to self-direct their own care. But one of the benefits is that they help them stay employed, right? And that's another benefit that we offer not just to individuals with disability, but also to our economy as a whole. And the final piece is that I'll say that, unfortunately, the healthcare system and the long-term care system, in many ways, both because of financing and regulations and just how those sectors are set up, can sometimes operate as silos. They're often fractured and scattered in many ways, right? I was asked last night at a really wonderful dinner with some colleagues, a part of your group, about the ways in which hospitals might think about direct care workers. And one of the realities that many people who work in that system will say is that there just isn't enough connection, right? Imagine if my discharging primary physician at the hospital would have paid more attention to the home care agency, would have followed up. Imagine if the social worker would have understood the vast array of services and would have checked in on what was at home and what wasn't. Would I have not been rehospitalized within 5 weeks? What would my health outcome have looked like? And I think that's a big question for us today. How do we better structure and synchronize the health and long-term care system so that we're improving it for all people involved? Despite their enormous value on multiple levels, direct care workers as a whole face a range of barriers. I'm going to cover just a few. The primary barrier that I want to highlight is low wages. According to PHI, the median wage for direct care workers, hourly wage, is $16 per hour. It has increased about 20% since 2013, though most of that increase was in the last few years thanks to funding from the American Rescue Plan Act, which I know people in North Carolina have also been watching and capitalizing on. We actually monitored that in the years that I was at PHI year to year, and it typically only increased by about 10 to 12 cents every year, and that was adjusted for inflation, right? So this is a wage that keeps many people in poverty. It's also one of the driving factors for why many workers leave the sector. Another factor that compounds with this is the reality that most workers are either relegated by their employers because they don't want to necessarily pay benefits, or by the economy because there isn't enough financing going into the system to part-time jobs. So many direct care workers often have more than one job. People might remember in the early stages of the pandemic, the news story that broke that nursing assistants who often had multiple jobs, and that they might have been one of the transmitters of viruses from one nursing home to another, right? The frame, and we worked with quite a few journalists, was quite punitive, when in fact what it reflected was the reality that out of necessity, most direct care workers, including nursing assistants, find multiple jobs because it's the only way that they can piece together 40 hours of work a week, right? Because of all of this, about 37% of workers live in or near poverty. A third issue is around training, and there's a lot of dimensions to this. One is that sometimes the training requirements are either non-existent or they are simply not strong enough. So that, for example, there are federal requirements around home health aides and nursing assistants, but there are no federal requirements for personal care aides who do not do the clinical tasks of the other two groups. In fact, no state, last time I checked, goes beyond 40 hours of training for personal care aides. A lot of training requirements are outdated. They're rooted in duration or the number of hours that a training transpires instead of a set of core competencies. They do not reflect today's acute clientele that is dealing with more and more so with issues like cardiovascular disease, HIV and aging, populations who are often have limited English proficiency or limited financial literacy, and so much more. And the infrastructure, the curricula, the modalities, whether it's hybrid, whether it's virtual or in-person or hybrid, are often not as well resourced as possible. At PHI, we often worked with state agencies and with training providers, and what we found is that the systems just weren't strong enough, right? How can we imagine that an adult learner who needs to be trained and educated in a very specific way with experiential exercises and so much more, how can we be assured that when they leave the training or 6 months to a year later, that they have accrued the knowledge and the skills and the confidence to succeed? And in fact, many training systems actually don't even evaluate for that. So this is a system in which workers are being asked to support and care for so many people who deserve good care. Career pathways are also limited, and by that I mean advanced roles within direct care. So for example, an advanced role that wouldn't require a home care worker to stop being a home care worker in order to become an LPN, right? Or direct care workers within that, but also career pathways perhaps into administrative and management positions in long-term care settings, or LPNs in other healthcare professions, or if they want, other sectors and fields, right? There are labor shortages, by the way, in many industries, and there are opportunities with the proper education and support and financial assistance for workers to have those career pathways. Finally, supportive services or holistic supports refers to issues like childcare, issues like their own affordable long-term care. Many workers are sandwich caregivers. They are supporting both their children and they are supporting their parents or another loved one in their community. Because of the opioid epidemic, there's also a generation of grandparents who are supporting children whose parents aren't able to offer that support, right? And so the more we offer supportive services like care or like transportation, the more likely we are to see this workforce succeed. A fourth area is burnout and stress. There's quite a bit of evidence that has been accrued, research evidence in the last few years about the impact of the pandemic on people's emotional state and burnout in particular, not just direct care workers, but also nurses and primary physicians and so many other people who were on the front line, but also were just strained in a variety of ways. Frankly, that experience preceded the pandemic. Burnout was something that was increasing more so, and there are multiple factors for that. The distinction with direct care workers is that they often lack grief support or bereavement support. They also often lack affordable mental health supports. And so the ability to recover from an instance of trauma, from a high stress emotional job can be really punishing. There's a phenomenal documentary that was produced, I would say about 7 years ago, called Care, and it follows 3 different workers over the course of their several months in their lives. And one of the workers is a home care worker who forms a really strong bond with their client, who eventually passes away. And the trauma, the grief of that loss is so punishing that she decides to leave her career as a home care worker and become a truck driver. And it's an episodic example, but it's something that reflects the ways in which, as a sector, we should be thinking about the mental health needs of this workforce. All of this means high turnover. If there are employers in the room, or if there are people who are monitoring workforce shortages, this is something that happens quite often. It often happens within the first 90 days, which just tell us how are we supporting workers in those first 90 days. At least 2 studies have shown that nursing assistant turnover is at about 100%, and about home care workers is about 80%. And that is really painful for the person receiving that care, right? A lack of continuity of care can be really damaging. It's also really expensive. I mean, some studies have costed out about $2,000 to $3,000 every time someone turns over for the employer, right? So imagine what that happens when you multiply that by the thousands or even by the millions at the national level. Desaline Watkins is a direct support professional in Chicago, and I love this quote. It's from the Direct Care Workers Story Project at PHI, where she says, learning how to decompress and separate the stress of the job from the rest of my life can be difficult. When you deal with people you care about on a daily basis, you tend to bring those cares home with you. It is very stressful being directly responsible for a person's well-being. Keeping residents safe is a huge responsibility that family give us, and I take that very seriously. And imagine if all of that is also the kind of care and seriousness they place in their families. What do they go to bed with, right? What do they think about when they wake up in the morning? The challenges in front of us is also how will we fill the number of job openings that are taking place in this country? Because of the growing number of older adults, but also the fact that people are living longer, and that requires often more paid assistance. PHI estimates that about 860,000 new jobs will be added between 2022 and 2032. It's the largest growth of any job sector in this country. Yet when you couple the number of new jobs that will be created with the number of job openings that are being created because people are retiring, people are exiting the labor force, or people are leaving direct care for modestly paying better jobs at McDonald's and Macy's and Buffalo Wild Wings, what you see is 8.9 million direct care job openings in the US. In North Carolina alone, about 207,000 job openings in the same time period. And so the question before us, the question that inspires me every day and when I work on this sector, is what must we change to make sure that those job openings are filled and that workers themselves can also thrive economically and in their lives, right? Let me guide us through a few solutions. I'll just do a quick time check. I want to guide us through a few solutions that I think are really relevant as we think about moving forward as a sector. The first is thinking about compensation. I mentioned that compensation in many ways is poverty level. Oftentimes people are relegated to part-time work, and more states and federal leaders are trying to think about what those solutions can look like. In Colorado, what it means is creating not just a livable wage, it means creating a competitive wage. And for people who understand what that means, or economists who might be in the room, it means that the cost of living wage means the cost of living varies by region of the state and the city, right? Competitive says you also look at the labor pool that you're drawing from, and you understand the other sectors that are drawing from that same labor pool. So in many areas, I mentioned that labor pool might be fast food, it might be retail. Buffalo Wild Wings, I passed a sign recently that showed that they were offering a $1,500 signing bonus if you took a job at Buffalo Wild Wings. And my question was, how will a nursing home, for example, compete with a $1,500 signing bonus at Buffalo Wild Wings? Also, how delicious are Buffalo Wild Wings at $1,500? They are very good for any Buffalo Wild Wings fans here. In Colorado, what they said is, let's create a higher wage for direct care workers, $15 an hour, which is $2.50 higher than other workers make in that country. And that's an acknowledgement that it needs to be both livable and competitive. We can also think about funding supplemental or hazard pay. Hazard pay can be used during emergencies. Supplemental pay might be bonuses. They're one-time ways in which those kinds of supports can actually be really meaningful, especially for people who often carry debt, right? This is a challenge for workers. At the federal level, at PHI, we argued for the federal government to take on a national compensation strategy, recognizing that there are so many variables that go into play in determining compensation in long-term care. It's about Medicaid rate setting. It's about local cost of living. It's about industry competition. It's about the state and federal interplay. It's about other payers, potentially, like Medicare or Health and Human Services or Departments of Labor, right? And we said, why don't we bring all of those agencies and all of those experts together to sort it out? What does a national compensation strategy look like in the long term that moves people, direct care workers, into a wage that's competitive, but in my opinion, into a salaried position that truly reflects the complexity and importance of their work, right? This can happen at the state level as well. We can create a state compensation strategy that acknowledges all those factors. Benefits and supportive services are also very critical. Benefits refers to health insurance, supportive services refers to childcare, to long-term care, to housing supports. In Virginia, they instituted a paid sick leave for home health care workers law so that workers can take up to 40 hours of paid sick leave when they're sick, right? When they or someone they love is ill. Financing is a huge question. This was asked last night, and I think it keeps a lot of us up at night, right? Medicaid can only offer so much, and it's increasingly strained over time in many parts of the country. It's also politically contested. And so what do we need moving forward to properly finance employers so that they can both deliver optimal care, but also create good jobs? Washington State has the first state in the country to establish a universal long-term services and support social insurance program where people pay into the program, and after being eligible and paying for a certain number of years, they can receive up to a lifetime benefit of $36,000 to help pay for long-term care. People know that's expensive and long-term care, so will it cover all of it? Of course not. But it does address some of the ways in which you might think of financing in addition to protecting Medicaid. Skills training and credentialing is essential. We need training programs that are rooted in a standardized set of core competencies that are modernized to today's clientele. I met someone last night who has talked about the enormous, phenomenal work that's being done in North Carolina. Credentialing is important for these workers. Oftentimes, if you're trained in one occupation or in one state at the national level, you can't necessarily carry that credential to another occupation, another setting, or another state. And this is especially ridiculous when you consider cities that are right next to each other across the border, right? So in Jersey City, which is a 20-minute bus ride from New York, a home care worker would need to be trained and certified just to work 20 minutes across the river, right? In the same city, that's expensive. It makes the workforce less versatile and the system less possible. Certainly, we can think about career pathways and advanced roles. Again, advanced roles where people can stay in home care or other direct care, a dementia specialist who understands the unique needs of people living with dementia, a transition specialist who can help people transition from the hospital to the home, a Care Connection senior aide who serves as a mentor to people newly on the job in the first few days. They come with elevated titles, elevated compensation, or career pathways. What are the ways in which somebody might want to go into a 4-year degree program to become a nurse, or maybe they want to go into construction, right? People should have agency and choices over the kinds of careers they want. This is a workforce that faces a lot of systemic barriers, and here I would draw attention to two issues: developing equity-focused initiatives. In New Mexico, an organization called Encuentro developed a Spanish language training program for home care workers that trains immigrants in the state on how to become home care workers and then places them at agencies and with families across the state, right? As part of that program, they also help them navigate legal questions because that can be a complicated approach, right? Associations have asked also for legal supports. Can you help us as employers develop legal services if we want to hire a foreign-born worker, given how complex that system is? And we can think, of course, also of ways in which draw more attention to the kinds of needs that unique populations can face. Here I'll be taking a different direction and say there should be targeted recruitment programs for men to enter direct care. And we should be thinking about older workers and how do you create age-friendly environments, or people with disabilities can play needs as well, right? We shouldn't make assumptions about what people can offer and not offer. The final points I make are data systems, right? We need to make sure that we're collecting the right data at the state level, that the data is being collected across agencies, departments of labor, departments of health, et cetera. We're measuring stability, compensation, versatility, and we're doing it in real time. So when an emergency occurs, we can know at any given point how many workers do we have in this part of the state and how much need do we have, and then compare that formula in a way that gives us a true measure of what's happening. And industry partnerships have always been a successful way in which states have moved forward. This means bringing together the employers, the payers, the consumer advocates, the workforce leaders, researchers, et cetera, to say, yes, we can pass policy, but what if we just figured out an industry way to improve training or create better pipelines into the sector? Wisconsin has created, for example, through the state, a certified direct care professional program where a worker, a nursing assistant, and a home health aide are trained on the very same level of core competencies, which creates that mobility that you often need. But they also have recruitment campaigns and training campaigns, and they've trained tens of thousands of workers in the last 3 to 4 years. And that's a great example of a state-sanctioned industry partnership. And we should always be making sure that we're including systems that bring the voices and experiences of workers, of students, and I would say of local business owners into the conversations about what needs to happen to make this system function. I go back to this place at least twice a year, this hospital. It holds a special place in my heart, no pun intended. Part of the reason is that I need to, my medical team is still there, and I need to do my twice a year appointments. Another reason is that it has, across the street, it has the best egg and cheese on a roll sandwich in the entire city. I kid you not, I can give you the name if you're a fan. But it's also an important reminder, right, of what needs to change in our country. And it grounds me in so much of what needs to be done. My story became a story. After it experienced, I became the miracle machine. It's also a pun on the ECMO machine that was used to keep me alive during the time. And I loved it. It was a great story. It focuses on miracles. And yet, with all due respect, I beg to differ. It wasn't a miracle that kept me alive. I was kept alive because I had a top medical surgeon who was halfway home when he heard about my case and was told, don't come back, he probably won't make it. And he said, I'll come back anyway, and he performed the surgery. I was helped by an amazing ICU team, by a hospital team, by a rehab team who guided me through every step of the process for years. And I was helped by friends and family members who helped me stay positive, who helped me go to appointments, and to colleagues who taught me so much about Medicaid, about hospitals, about reimbursement, and so much more. The year of the heart attack, about 6 months after that, I went back to work full time, and my research director at the time was named Abby Markland. And she and I were thinking about a major initiative, a research project that would help draw attention to the direct care workforce. And this issue of why didn't I qualify for a home care worker haunted me. So we designed a 2-year education program called 60 Caregiver Issues, where over the course of 2 years, every 2 weeks, we released a new idea to help solve the workforce shortage in home care. And to bolster each idea, we released a new research report, a new fact sheet, a new story, et cetera. It was very ambitious. Some of my colleagues said it was psychotic, but it actually, it did quite a bit for our organization and for the issues. Some of the issues went viral, and it went into the New York Times, the Wall Street Journal. I interviewed on Fox News. I mean, these were topics that really resonated with people, and people began speaking about a home care workforce shortage and what could be happened. And what I want to leave you with is this, is that we need to stop seeing these issues as miraculous and as inspiring as they are, as individual or episodic. They are, in fact, parts of systems that were designed in such a way, and they can be redesigned in a complete different way. We need large-scale changes across policies, across institutions, across narratives to rethink what we think about older people and people with disabilities. These are not low-skilled workers. These are workers that use a number of skills and problem-solving and emotional supports to keep a lot of us thriving and alive. If we think about them less as miracles, even tiny ones, and more as moments that all of us can activate, and those moments become momentum, and that momentum becomes a movement, then potentially all of us, regardless of where we are seated, can play a part in doing that. And it starts here in this room with our tiny fractured hearts, with our limitless imaginations. Thank you.
We have time for questions now,
Yes, ma'am.
and we're going to go back to the QR code before your slides. Sorry, it wasn't at the end there. And you can submit questions online using this QR code. But for initial questions, I'm wondering if you can talk about, given the significant challenges facing direct care workers that you've gone through, how can we balance the kind of immediate policy changes like wage increases with long-term structural workforce reforms that we'll need to get to those big numbers that you talked about?
Yeah, it's a great question. I mean, my first response is that both are clearly really necessary. We would often get asked at PHI, what are the low-cost, free approaches we can do to address this issue? And, you know, we would chuckle a little, but we would say, you actually can do that. A proclamation is a great thing to do as a city, right? So both of them are certainly important. The one answer I would offer as a solution is that several years ago, we did a review of what states were doing in terms of designing studies and reports on the direct care workforce. And so what we found is that there were at least 16 states that had brought together a bipartisan, multi-stakeholder group of actors in their states. Some states paid for it, some did not, and they were paid by private money. But they basically came to the table and they said, here's the challenge in front of us, direct care worker shortage, direct care worker challenges, client need, et cetera. What are all the ways in which we can address that? And states began developing blueprints. Similar to multi-state plans on aging, they developed multi-state plans on direct care workers, right? Philadelphia has, in my opinion, the most stellar one. It spans 7 areas, and they include things like livable wages, narrative change, which is not something you often see in policy circles, right? But there are many other states that have done that. And that's a way to keep your eye on what can be done today versus what you need to lay the groundwork for today that can be done 3-5 years from now. Yep.
Thank you. How can you talked about integrating the voice of direct care workers. So how can we better integrate the perspective of direct care workers into the policymaking process, that we are ensuring that the solutions that are being developed are practical and impactful for the people who are impacted?
Mm-hmm. Yeah, it's a great question. I mean, I think there's various methods, and it's a journey as well, I should say, to become worker-centered. I think in our programming it takes years, right? And it takes concerted effort. It can start with making sure that workers, students, and I would say local business owners are a part of panels, that they're experts, not just testifying on their lives, but adding their ideas of what needs to be changed for policy, right? making sure that their stories are integrated into the materials, the videos, the resources that are distributed at broader levels, training them as media spokespeople, because when these stories hit the press, I know it's hard to get sometimes press on long-term care, that workers can actually speak to why it's needed, but they're not just speaking to their own lives, which is really critical. They're speaking about what needs to change at the systemic level, right? The other piece is that we worked with Maine as one example to develop a direct care worker policy advisory council, where the state themselves, I think it was the Department of Health, convened regularly a group of direct care workers, to meet regularly and review all of the recommendations that they were putting together as kind of paid professionals, right? And they would ask them questions, and they were PHI facilitated in such a way that, really respected where people were at in terms of their knowledge on policy, but that they were being integrated into that way, right? There's lots of other ways, but those are the ones that come to mind.
Great, thank you. And we've got time for one more.
Okay.
What do you think about initiatives to empower and compensate family members to engage in direct care?
Yeah, it's a great question. I spoke last week at ACL, the Administration on Community Living, about that dyad relationship between family caregivers and direct care workers, and how it's so often neglected, and what we can do to strengthen it. And I would say two things. One is to remember that they're often the same people. Many direct care workers are family caregivers, and because of consumer direction, many family caregivers can be paid through those programs and are independent providers, right? But if we think of them as distinct and we think about the role of family caregivers, I think certainly making sure that family caregivers are, one, aware of consumer direction programs. There's little uptake in those programs, and they can be paid and compensated, right? Making sure that we're offering enough training and resources for family caregivers to understand, for example, the proper way to lift somebody. It's one of the main reasons why people get injured, both the person being lifted and the worker. Nursing assistants have one of the highest injury rates of any occupation in this country. They can be trained on things like, how do you ask sensitive questions? How do you bring up an issue like dementia, et cetera? And then I think, similar to the previous question, making sure that family caregivers are part of the advocacy process, because I'm a family caregiver as well, we bring a really critical voice to the delivery of care. Yep.
Thank you so much. Really appreciate all your contributions and bringing us this information this morning.
Thank you so much.
All right. Thank you again to Robert for that fantastic talk to kick off our day. Next, we're going to move to our plenary session today. All right. We're going back to, here we go. All right. And our plenary session is titled Ensuring Robust Long-Term Supports and Services for a Changing State. And we have, as our moderator today, we have Paul De La Mater from UNC Chapel Hill. And Dr. De La Mater is an associate professor in the Department of Geography, a fellow of the Carolina Population Center, and a fellow of the Shep Center for Health Services Research at UNC Chapel Hill. In his research, Paul uses geographic information systems and statistical and spatial analysis to study access to and utilization of healthcare services. For nearly 15 years, he has worked with the Michigan Certificate of Need Commission to develop data-driven approaches to predict future need for healthcare services across the state. And Paul's going to kick us off and introduce the rest of our panelists today. So thank you so much. And I'm going to find your slides too. Yep.
Thanks, everyone. So excited to be here today. Thank you to... there we go. Hi. Now you can hear me? I have a very loud voice. I could probably do this without the mic, to be honest. If you ask people in my classes, the ones that sit in the front usually sit back a little bit. So thank you, Robert, for an amazing keynote talk, for sharing your personal story with us, and for really laying out the complexity of the issue, the challenges that we're facing, but also opportunities and potential solutions. I am so excited to be here today doing this. This is actually my first time moderating a panel. I'm a little bit nervous, but I'm feeling good about it thus far. I will introduce my the panelists here in a minute, but I will say the only reason I told Michelle, yes, I would do it. I agreed to do it because she told me, yes, Paul, you can present slides as a professor. This is a very important part of my life. And so as a geographer and someone who studies population health, I did want to talk a little bit more about population health. I did want to point out there's some great data in the data companion that was provided for everyone today. And some of the things, I'm glad I didn't find exactly what I was going to talk about in here. But it's there for you to follow along if you want to. So I did want to talk about population change and our changing population here in North Carolina. And let me see if I can get the slides to work. Again, I think everyone in the room knows that our state is among the fastest growing states in the U.S. And that it's continuing to happen and happen and happen. It really hasn't slowed down. It's been this way for years. And it's kind of all over the state. The whole state's growing, but we also have certain regions that are really outpacing other cities throughout the state and throughout the U.S. So next I'm going to try this. I'm having a little bit. Oh, yeah. So graphs. Wouldn't be a professor if I didn't show graph, right? So here I have a population pyramid that shows, I want to lay out kind of how we got here and then where we're going as far as population change. And this shows the population structure of North Carolina, in 2010. And you can see we have a relatively the same amount of people through all those younger age groups and through the people who are in their mid-50s or so. And then we get this pyramid shape at the top. And we fast forward to 2023, right? And you can see that we've added some and it's bulged a little bit. And I made this nice graphic there to show you where we actually gained people in the last 13 years. And this was a helpful visualization for me thinking about how our population has changed and then where it's going. And as you can see, we've gained quite a few people in the younger adults, but also in people who are between 60 and 80 years old. You can see massive increases in those populations over the last 13 years. And now if we take 2023 as our base and we think about what a population might look like in 2030, you can see continued growth in those older age groups. And then projecting out to 2040, you can see what we're thinking about in the next 15 to 20 years. And so so I just wanted to point out again that, I think everyone in the room knows a little bit about what's going on, but it's not just the older population that's changing in North Carolina. We're also adding people across all age groups and are expected to, given the high growth in our state. We're going to add a projected 2 million people plus 20% by 2040. And then the age 65 and above population is expected to go up nearly 1 million people by 2040 as well. And I wouldn't be a geographer if I didn't bring maps. Now I get to collect my geographer card for the day. And I have some maps just thinking about where the population is changing throughout the state. And I made a couple of maps of the proportion of population in North Carolina counties that are older than 65 right now. And you can see some in the west and through the middle of the state and some in the east where we have quite a high proportion of the population. And then the what we expect this to look like in 2040, where the whole state has kind of come up together, it looks like. But we're seeing just an intensification of the proportion of population who are 65 or older over this time. And then we can look at change and really look at where we're expecting a high proportion of change. A lot in that lightest blue and the blue color through the middle of the state. And I will point out places like Wake County here that has a high population. So even a small proportion or percent change in a place like Wake County can mean a lot of people here. So that's my part about population change. I do want to lay out here that I've only talked about really here the age 65 population, but as we heard before and as we know, right, LTSS isn't just about the older population. We have to think about everyone that may need these services. And I found a great graphic in here in the data companion that was, I think, more than half of people, Medicaid enrollees in LTSS are younger than 65. So it's important to consider that. And also we should think about not just the need, but as Robert pointed out, the workforce, the people who provide these services and supports, and those who coordinate it for them. And I think that we're all pretty clear-eyed about the challenges that we're facing to build a flexible system that can meet the needs of a changing and growing population. And I'm excited to walk through that with my fellow panelists. Now I'm going to stop talking and let the real experts talk here. I'm joined today by Erin Kent. She is an associate professor and associate chair for research in health policy and management with me at UNC Chapel Hill, although she is over in Gillings School of Global Public Health. She currently serves as the chair of the Caregiving Research Special Interest Group for the American Psychosocial Oncology Society. In partnership with the Shep Center, she is leading the development of a data dashboard and data-driven implementation plan to accompany the North Carolina Multi-Sector Plan for Aging. Welcome, Erin. We're also joined by Sabrina Lee. She has deep experience serving in a variety of roles at the North Carolina DHHS. She is currently Deputy Director for North Carolina Medicaid and Long-Term Services and Supports at the Division of Health Benefits. She has also served as Assistant Director for Family, Home, and Community-Based Services, Chief for Home and Community Care Services, and Director for the Office of Long-Term Services and Supports. We're so lucky to have her. And finally, we have Tracy Hayes. She is the Area Director and Chief Executive Officer of VIA Health, where she leads the executive team and oversees general administration and daily business activities, including the recent launch of VIA's behavioral health and IDD tailored plan, VIA Total Care. She brings nearly 20 years of experience with North Carolina's Medicaid and state-funded programs to the role of Area Director and CEO. Prior to accepting this role, she served as VIA's General Counsel and Chief Compliance Officer. So that is our panel today. We're going to start off with a question. We learned about the challenges in long-term supports and services, including difficulties identifying what services you need, accessing those services, developing the workforce. And it's clear the system is very complex and oftentimes difficult to understand all these various components. So I'm going to ask Sabrina if you can start us off. Can you provide a little bit of a level set for us for when we're discussing LTSS? What does it encompass, and how do we understand how these things fit together?
Good morning, everyone, and thank you, Paul, for the question. I think Robert did a fantastic job in level setting for us long-term services and supports. Clearly, long-term services and supports occur at the beginning and ending of life and all throughout life. I think it's important to understand that when we have a discussion about long-term services and supports, that there's always a triggering event. Long-term services and supports typically are initiated at a healthcare crisis. At some point, there is a spell of illness that either exacerbates an existing chronic condition or causes a change in lifestyle and ability that necessitates that that individual receive some assistance with what we refer to as activities of daily living because of a permanent or temporary impairment. I think that it is important when we have a discussion about long-term services and supports in the settings of care that we understand that long-term services and supports are delivered in community. And often we want to differentiate between community-based settings and institutional settings, but I would would argue, and I feel like Adam would agree, that even when we talk about institutional services, that exists within community, because the individuals delivering those services are our neighbors. Those settings of care where we see long-term services and supports are home care settings, home health settings, assisted living facilities. They are delivered by family caregivers. They are delivered by friends and neighbors, yes, in a nursing home, in adult day health centers. They are both Medicaid and non-Medicaid. They are paid and unpaid supports delivered by individuals, as Robert shared with us, with various levels of training, expertise, credentialing, and licensing. In fact, CMS has modified its definition of direct support workers to include some licensed professionals. I think we learned the lesson from COVID that helped us redefine the terminology of essential workers, and that we came to understand in COVID that essential workers are not only individuals who are delivering hands-on assistance with activities of daily living, but could include others who support those individuals and providing additional supports. So I think that is kind of a way to jump off in our conversation about long-term care or long-term services and supports, to expand and broaden that definition, because we certainly know that some child born today with a complex medical condition will need long-term services and support throughout the course of their life.
Thank you. Erin?
Thank you, Paul. Let's see. Is this on? Okay. Thank you, Paul, and thank you so much, Sabrina, for getting us started. I will say that I think that other than for those who work directly in this space, for those of us who have come up in sort of health service research settings, there has been a big difference in training and attention to long-term services and supports than into more formal healthcare delivery. And I'm so gratified that NCIOM has taken the time to organize this day around LTSS because of how prevalent, how important it is to the duration of really all of our lifetimes. I'll quote a very famous quote that people who work in caregiving advocacy and policy know all too well, but the former First Lady, Rosalind Carter, has been made famous by saying, there are 4 kinds of people in the world: those who have been a family caregiver, those who are currently a family caregiver, those who will be a family caregiver, and those who will need a family caregiver. So critical to this conversation about LTSS are the family and friend and partner caregivers, sometimes called informal caregivers, but most of us would argue there's nothing informal about the care that they provide, that are part of the LTSS sort of ecosystem. Fortunately, NCIOM has provided us all kinds of data. So there's data at your fingertips in terms of things like the numbers of people who we might consider are serving as a family caregiver right now, as well as all kinds of information on the changing demographics, like Paul showed us earlier, and sort of the cost and the needs, the job projections and the cost of all of this care. But our best estimate is about 1 in 5 North Carolinians are currently acting as a family caregiver. And these folks do everything. They do everything alongside our direct care workforce. They're working many times in a shared care model. They're helping with activities of daily living, instrumental activities of daily living, clinical tasks, and often with very little preparation for those triggering events that often put them into the role of family caregiver. So I would also just say, as we get off in this panel, that any conversation about LTSS also must include their voices and their experiences.
Thanks so much, Erin. Tracy?
All right, good morning, everyone. I always like to start these types of panels with first making sure Does everyone know what VIA Health is and what we do, and what is a local management entity managed care organization in North Carolina? Do folks in this room know what that is? Because usually I go to rooms and maybe only about a quarter of the people in the room know what an LME MCO is, and it's a long acronym. So VIA Health is one of 4 remaining area authorities, or LMEs, in North Carolina. And we're public, we're governmental entities, we're public political subdivisions of the state of North Carolina. And each of us are responsible and have been responsible for decades for delivering or managing care for individuals with intellectual and developmental disabilities, serious and persistent mental illness, or severe substance use disorder. The organization that I run, VIA Health, formerly was known as Smoky Mountain Center. It has operated for over 50 years, and we actually manage care in the far west. We manage care in 32 counties of North Carolina, which include the counties that have been heavily impacted by Hurricane Helene. So our administrative headquarters are in Asheville. So it is also just a privilege to be here and to experience life that's a little more normal than what we're having every day right now in the West. So we have a lot of experience managing long-term services and supports, particularly for people with IDD, with intellectual or developmental disabilities. We recently launched tailored plans, and I'll talk about that some more later. But through tailored plans, we are also managing a number of the other programs, the LTSS programs, through NC Medicaid. That includes programs like personal care services. So one of the things, of course, that we have learned through the years is that people have better outcomes when their care is not siloed. Right? When all of the care team is working together and meeting regularly, especially for people who have more complex conditions, like conditions that require long-term services and supports. So, we recognized quite a long time ago that it was important to begin to integrate services and integrate care management. We did a pilot with MAHEC. We do a lot of great work with MAHEC in the western part of the state, and did a pilot with them to try and improve physical health care for people with IDD. And we've been very successful at that, but there's a lot of challenges. Not all primary care practices or physicians have familiarity with serving people who have really significant intellectual or developmental disabilities. So we know that more training and support is needed. One of the things that we have learned also is how important it is to do things like medication reconciliation. We have an entire pharmacy team that just on their own initiative created a medication reconciliation program where they try to pull together all the medications that some of these people are on, because many of these people are on a lot of medications. And what we have found is that sometimes practices aren't talking to each other. And families may not have a great understanding of how medications can interact, and we have found individuals to be over-medicated or to have medications that are contraindicated. So those are just some of the ways that we have been working to kind of integrate the services and supports that we manage, and integration and whole person care is a really important component to long-term services and supports and to having successful outcomes. And it's not just for people with IDD. We manage services for a very complex population, many of whom have physical disabilities, but also people who have what we talk about as unseen or invisible disabilities, right? They're not apparent at first glance, but people who suffer from schizophrenia or who have really serious and persistent mental health challenges that require long-term services and supports for them to be able to live successfully in the home and community of their choice. And that is one of our core values, and our core mission is really to help people live successfully in the home and community of their choice whenever possible. And I'll talk about some of the programs we have to help integrate people back into their communities and how important that is for North Carolina. But thanks for having me.
Thank you so much. So we're going to move on to the next question, which is thinking about the characteristics of LTSS. And we know that there are a lot of different services, types of providers, payment method or payment models, and ways that we access these services. And there are also challenges in quantifying all of the questions we have about this to develop data-driven solutions. So Erin, can you tell us more about the challenges in collecting and developing data for LTSS?
Sure, there are several challenges. I think that a lot of the ways in which individuals access, receive, or even need these services are very siloed to Tracy's earlier point. And so a lot of it is just none of these data don't sort of live in one place, and it really depends on on the questions being asked. But I'll probably speak. I think that we're not obviously just talking about caregiver-related issues, but I think caregivers are a nice illustrative part of this problem, and that there are not necessarily formal recognition of many caregivers in many spaces, right? So I'll speak about sort of just hospitalized individuals and say that we are one of the very small handful of states that did not pass a bill, a state-by-state bill called the Caregiver Advise, Record, and Enable Act, which mandates hospital reporting of caregivers. So identification of a caregiver upon someone being hospitalized, and then standardized recording of that individual's contact information in the medical record, and then using that information to help advise a caregiver of a care recipient's discharge, and then use that opportunity to help train them in proper discharge planning. And I only say that because we don't really even have a really great sense of who those caregivers are, when they might need help, what their unmet needs are. Some of the best data that we do have are from our state's behavioral risk factor surveillance system survey, which has done a caregiver module every 3 or 4 years for the past decade, and that's how we get that 1.3 million number of caregivers. But that's just one illustration of how we're really missing opportunities to do surveillance in this space of unmet needs. So I don't even think we fully can capture the amount of need that we have in the system. But I'll sort of turn to my colleagues and see what they think about ways in which, like, challenges that you think that we might have in quantifying the need and access challenges in LTSS.
So data is a huge challenge for all of us, and part of it is the siloed, and part of it is just there isn't a great mandate or mechanism even to require some of the data and reporting that would really be helpful for us to try and drill down in some of the areas that we could make improvements. I am actually kind of interested in exploring with you, some ways in which, the LMEs could potentially work with UNC on providing some of the data that we have access to. But most of what we've done has really been organically grown and us kind of building out data. We manage care for individuals in intermediate care facilities for IDD, so ICF facilities. We actually work very hard. We have a Money Follows the Person program that we use to try and actually help individuals, in some cases, who have lived in ICFs for decades. We have been successful in helping them transition back into the community with wraparound services and supports. So we've got some great data about that transition work. We have some good data around the programs that we manage, but then there's programs that we don't manage, right? Like so the CAP-DA and the CAP-C program in Medicaid. We manage a program that's now called the North Carolina Innovations Waiver. It used to be known as the CAP MRDD waiver. It started out as a community alternatives program, which is what these CAP waivers are. And because these waivers are separated, there's a lot of challenges with the data. So even, for example, incident reporting. Incident reporting is done through the Division of Mental Health for these programs. but only the innovations providers are required to report their data in the IRIS system, which is a system that the Division of Mental Health uses. The CAP-C and CAP-DA providers aren't required to report in that, so there's not a good way to aggregate the data, because so much of it, as Aaron mentioned, is really siloed. So I think the challenge for us as a state is how do we get to better ways of reporting data, better ways of accessing data, even also through the Health Information Exchange, which has had its own challenges in lifting that and getting the right access to all the players.
So for me, I think when I think about data upstream in the traditional LTSS world, certainly being able to marry Medicare and Medicaid data is huge for us and presents formidable challenges. On the other end of the stream, being able to marry data for non-Medicaid LTSS users to Medicaid LTSS users. And then you're referencing the Carter Center and Rosalind Carter, the fact that we aren't actually able to quantify and quantify the value of the informal caregivers. So I don't know that we actually know the true cost or value in that. I think presents huge problems as we are trying to determine the best way to position our resources for an aging state.
Thanks, everyone. This actually mirrors my experience in Michigan working with Certificate of Need, and that it's just hard to find data, and often we don't even know which data we need, and so the request can be quite difficult to try to work that out. So, okay, we're going to move on now. We know that there are some policy changes coming aimed at improving care for individuals who may be transitioning between institutional care and home and community-based services. So Tracy, I'm going to start with you on this one. Can you tell us about these changes and potential opportunities for Medicaid beneficiaries to receive services in their own home or community settings instead of institutional settings?
Absolutely. And this is probably some of the most exciting work that we do. It's very rewarding to help people who have lived in institutional settings, in some cases, as I mentioned, for decades, get to have a home of their own. And it's incredibly exciting to be a part of this in North Carolina. So probably the biggest change that has happened for Medicaid in the last 6 to 12 months is the behavioral health and IDD tailored plans launched. So most of you are probably familiar with the launch of the standard plans, who launched a few years ago, and the tailored plans launched on July 1st of this year. And so the tailored plans are really specialized health plans for people with Medicaid and also for people who may be eligible for state-funded services. And it's really focused on complex high-risk conditions, people, again, who have intellectual developmental disabilities, traumatic brain injury, serious and persistent mental illness, or severe substance use disorder. And so that's the population of Medicaid beneficiaries that we manage services for. And again, so what we're trying to do is really integrate the care, right? So that instead of having the care where the Medicaid program is managing pharmacy and physical health, and we're managing behavioral health, because we've been managing behavioral health since 2012 for this population, but we didn't have responsibility for the physical health and the pharmacy side. So now we have that responsibility for managing the care for the whole person. And that includes a really robust care management benefit. And that care management benefit means that individuals have the ability to have an assigned tailored care manager. And that could be somebody who works for us, or that could be somebody who works for a provider agency, who is assigned to them to help them navigate the care system. Because for people with complex conditions who have, they don't just have a primary care physician or an OBGYN, right? They might have 12 different doctors. They might have a psychiatrist, they might have a psychologist, they might have a doctor who specializes in a specific condition that they have, along with their primary care, and a number of other health providers. And so the goal of the tailored care manager is to help bring all those providers together and have multidisciplinary care team meetings where they actually sit down and develop a care plan. And that care plan is designed to help the individual focus on what are their goals, how do we help them achieve those goals, how do we identify concrete steps throughout the year that are going to help them progress and improve their health outcomes. So that's really what we're trying to do with tailored plans. Some of the other programs, that we have, so for a long time we have managed the Money Follows the Person program for people with IDD. And again, this is a program where we get a certain number of slots every year to help individuals transition out of an intermediate care facility or state level intermediate care facility into the home and community of their choice. And this is a really exciting thing because for years, most people have assumed that once you go into an ICF, you're in an ICF for the rest of your life, that you're never going home, that you require that level of care. But what we have learned is that with the right sets of wraparound services and supports, people can live successfully in their home and community of their choice. And so that's what we are really trying to promote. We also we manage the Transitions to Community Living program for North Carolina in our region. And that's a program for people with mental health and substance use issues who are either living in adult care homes or at risk of going into an adult care home. And the idea is to try and divert people away from adult care homes, keep them safe and healthy in their communities through supported employment, through wraparound services, including some housing supports that help them get started. So those are really exciting programs. And then I think the most exciting thing is VIA applied for, and it was a competitive bid, and we were awarded recently the statewide, it's a new program that Medicaid is offering, the statewide Money Follows the Person program for aging or people with physical disabilities. So we are actually beginning the process of going into skilled nursing facilities. We have hired staff statewide, and we are going to be working to help figure out if there are people living in skilled nursing facilities today who want to move back into the home or community of their choice and have the ability to do so, right? That with the right wraparound services and supports that we can do that. And the great thing about all this is that it's actually cheaper. It's more cost effective for people to live in the home and community of their choice than to live in an institution. Institutional care is expensive. And there's just some amazing stories that I could share about just people who literally have lived in these settings for years and years and are now thriving in their community. They have jobs, they volunteer, they go to church, they are experiencing life in ways and having meaningful day. It's a term we talk about a lot, that everyone deserves to have a meaningful day. Because most people living in institutions don't have a whole lot of meaningful days. And so these people are getting to experience that in some cases after many years of living in institutional settings. We have a lot of programs we manage, and I could go on and on and on. We manage the 1959 program, but I will give you some data that since we began operating these programs, and as of this is data from spring of this year, we have supported more than 129 transitions out of ICFs through the Money Follows the Person program, over 1,000 transition to community living transitions away from adult care homes. We also have a program that we are doing with a Section 1115, part of the Section 1115 demonstration waiver to help individuals re-entering society from incarceration. And we have supported 12, that's a brand new program, we have supported 12 individuals through that program, which is an exciting thing. So, I actually do have some data, Erin. I have some data that I could share about some of these programs and the work we are doing around personal care services and the innovations waiver, but I feel like I've used up enough of my time, so I'll pass it back.
Go ahead, Sabrina.
Well, Tracy, thank you, because you actually took me down memory lane. Not only is it cheaper and for folks to live at home in the least restrictive setting, it's the law. Since the passage of the Olmstead Act, we are required as a state Medicaid agency to provide care for individuals in the least restrictive setting possible. And I'm proud that there are people in the room who were part of DHHS in 2006 when we, along with maybe 17 other states, applied for a competitive bid to become a Money Follows the Person state. And so we, in fact, have 19 years of data over the maturing of our money follows the person. And yes, it is a wonderful thing. And there are some amazing stories of how individuals who had lost hope of being able to live in community in a least restrictive setting have been able to do so. And we are excited. Well, first of all, we are grateful to our area agencies on aging, who for a number of years provided transitional support to individuals who were seeking to move out of an institutional setting to return to a community setting. And yes, we are delighted that recently this summer we were able to award the contract to VIA to expand and mature the opportunity for transitional supports. I think Robert talked about the fact that some of the services that are within the Medicaid program are among the best kept secrets of Medicaid. You mentioned the authority that we have with 1915C. And certainly we are excited about the opportunity to leverage our 1115 authority, which implements managed care, both standard plan and tailored plan, to enable us to re-envision how we deliver services. And by that, I'm talking about social determinants of health, to actually use Medicaid funding to provide some non-traditional services that impact wellness. I think I can't not use my time to talk about another well-kept secret that we launched 2 years ago, and that's NC Lifts. And that's linking individuals and families to long-term services and supports, because we know that a lot of times people don't access benefits like our waiver services because they don't know about them. Pretty much everybody knows about PCS, but they aren't aware of the resources, the rich resources that are available through our 1915C waivers.
Thank you. Erin?
I'm really excited to learn more about NC Lifts, because I think one of the big issues, I think, is the just lack of knowledge and awareness about these different programs and how people sort of enter into the systems of receiving systems and supports can take so much time, and many families don't have that time when they're dealing with care needs. But the only other thing I would say is that we need to be, in North Carolina, we need to be aware of both conversations that are happening within our state, because the ways in which LTSS are delivered vary so much state to state. If you've read one state's waiver program, you've read one waiver program, you've read one waiver program. They vary so greatly. But there are a lot of national conversations happening right now as well. We now, for the first time ever in our nation's history, have a national family caregiver strategy that was made possible by the RAISE Act that was signed into law in 2018. And that has a bunch of national goals, and including working with states to bolster more resources for family caregivers who are accompanying their care recipients who need LTSS. So I would say we need more transparency. So I'm glad to hear about the NC Lifts program, and there are other programs, many of which are mentioned in, and we'll hear about this later today, in the multi-sector plan for aging, all ages, all stages, about for fostering more communication about some of these existing services and supports.
Thanks so much. We are running a little bit behind on time. So I think maybe what we'll do is we'll do one more question. And as moderator, I get to pick which one. So you guys, are you wondering which one? This is the one I think I would like to hear your thoughts on the most is, what is one thing that you would want policymakers to know about long-term supports and services, and how to improve delivery of them? And I'll go ahead and start with Tracy on this one.
Sure. Well, I'm going to probably echo a lot of our keynote speaker, who was fantastic, and I hope I can connect with him later on some of the work we're doing around that. But, the DSP workforce, it cannot be overstated how important it is going to be for North Carolina to support and grow that workforce. I know this is a room full of people who like data and who probably have already read this, but I will just tell you that Mercer issued a report in September 2024 that looked at healthcare workforce shortages across all 50 states. They really drilled down into the data. And they're saying, like, total, the U.S. is expected to have a shortage of 100,000 healthcare workers nationally by 2028. And in particular, if you look at the maps that they have, some states are doing better than others. North Carolina is one of those states that they are projecting healthcare workforce shortages for across a number of sectors, including CNAs, for example, and home health aides, which are just crucial parts of the overall healthcare workforce. So at VIA, one of the things that we are doing, we applied for and got a grant from the Dogwood Health Trust, and we are hiring a full-time person whose job is going to be nothing but supporting our providers and our Provider Advisory Council with recruitment and retention of direct support professionals. Because there's a number of things that we are learning. We've got to be more creative. It is not always about money. Pay is important, right? Like, we have to pay these people for the value of the work that they provide. I thought that Robert did a fantastic job of talking about the challenge and stress of this work and how important these people are. For the IDD community, they are their lifeline. This is what enables people to live in their community. People with cerebral palsy, people with Down syndrome, people who have the right to experience life to its fullest, but they need help doing so. And so it's so critical that we have a well-trained and well-supported workforce. And, we've got to get more creative. One of the examples that I shared with somebody earlier that they wanted me to kind of share is, one of the more creative examples I've seen was a provider agency kind of surveyed and tried to figure out, like, why are we losing them? Why is the turnover so high? And one of the challenges, which I think Robert mentioned, was childcare, right? And in many cases, they barely make more than what they're paying for childcare. And so this provider group said, well, let's see what we can do about it. And they actually partnered with a child care agency to get discounts for their staff and said, if you come work for us, you will get this discount at this child care agency. You will get preference to get your kid into this child care agency. And that's just one tiny example of how the industry has got to be more creative and how policymakers have to be more creative so that we can support this, because the work that they do is incredibly valuable. We need them. And they deserve to be supported. And so I think that's the most important thing that I would want policymakers to know. The second most important thing, I would be remiss if I didn't say, we need more innovations waiver slots. We need more 1915C slots. All the 1915C Medicaid programs are slot-based. And unlike the rest of Medicaid, which is an entitlement program, you get the services that are medically necessary. 1915C services are waiver services. So they are not entitlement-based, and you have to have a slot to get them. And those slots are funded by the General Assembly and CMS, and they're limited. So by way of example, I think VIA has right now today, we've got 2,181 people on the wait list to get a North Carolina Innovations waiver slot. And we don't have the largest list. Statewide, there's about 10,000 people on the wait list to get those. So that would be my other thing I would want policymakers to hear, is how important it is to expand those slots so people can get the care that they need.
Tracy, can I ask a quick follow-up question?
Sure.
How long do people typically wait on those wait lists?
The current wait time is about 10 to 12 years.
It varies based on
Yes.
the area.
It does.
It does.
If you live in a more urban area, the wait time is longer. And so we are actually seeing situations where families are moving. They're making decisions to move to less urban areas in the hopes that they will get moved higher up on the list to get a slot.
Thanks, Tracy. Erin?
Yeah, I think we need to hear more stories from families. I was yesterday at the Caregiver Nation Summit, which was hosted by the National Alliance for Caregiving. And one of the things that continues to strike me, and I am an epidemiologist and a data person, is just the power of stories and how much we learn from really spotlighting, asking deep questions about families' lived experiences as they go through these incredible programs, and when they get services, the kind of success stories that we hear, but then also the challenges that people continue to face as they either wait for services or end up having to obtain more higher level of institutional support because they can't get the services they really need and deserve in their own homes. So I would say we need more stories, more spotlighting of families to understand what the real needs are, and that needs to be in front of policymakers as much as possible.
Thanks so much. And Sabrina?
Well, Paul, I am a policymaker.
Yeah.
So I think what I would want to share is that I'm proud of the fact that North Carolina DHHS and Medicaid specifically values the rich collaboration that we have with our provider community over the course of years. I'm proud when I'm able to travel, as I was recently, to a national conference where North Carolina was spotlighted. The things that we think about when we look at this formidable issue around direct care workforce is the untapped resource of informal caregivers, and by that I'm talking about consumer direction. I'm proud of the fact that North Carolina has modified in our CAP-DA waiver our consumer direction initiative that now has what I'll call a hybrid consumer direction because it infuses a level of support that's not available in traditional consumer direction, and we call it coordinated family caregiving. I would want you to know that as we think about how we might create maximum flexibility in our policies in the future, our bottom line is that the limit of our flexibility cannot introduce risk that we cannot measure, monitor, and mitigate. That for us is a bridge too far. And I know that we all share in the goal that as we look at innovation and flexibility, that we not sacrifice quality and safety for both the care recipient and the care provider. I think that as we look at innovative ideas, we have to think about sustainability, and that's to our legislators. Yes, we need more slots and we need more flexibility in how we use our dollars, but it has to be also scalable. We understand that when we introduce an innovative program in resource-rich Wake County and Mecklenburg County, it also has to be scalable to Murphy and Manio. And I think those are the kinds of things that we engage and we sort of use as a rubric in terms of go, no go for programs and services of the future.
Thank you so much. And I believe we have time for audience questions. Yeah. Go ahead.
Okay, we've got some lots of audience questions. First, thinking about those who kind of fall in a gap and maybe don't qualify for Medicaid, what can be done for those who don't qualify for Medicaid but need direct care assistance to be able to continue to live at home and can't afford to pay private pay? Are there any programs or services that we can be thinking about?
So it's very limited. One thing, we also manage state-funded services, and these are for individuals who are underinsured or underinsured and don't qualify for Medicaid. At least for individuals with IDD, we piloted a service that we call long-term community supports. And so we are able to use some state dollars to pay for long-term community supports. But again, it is very limited, and it's especially limited, I think, for the aging population, which is why so many families are just taking it on their own, right? And trying to figure out and navigate, managing their day job and taking care of their aging parents and taking care of their kids, and it's the sandwich generation. So I wish I had better answers for you, but that's kind of what I can offer, at least from the populations that we manage.
So I would say it depends on the age. I think North Carolina, and yes, limited, but when you are a family caregiver, having even some help if it's respite through the Lifespan Respite Act, that's helpful. And those are programs that are not well known. So I think it depends on where you are in the geographically. In some cases, we have a program of all-inclusive care for the elderly, PACE. PACE does take private pay. We are working on creating some relief for families who might otherwise qualify for CAP-DA, but because of the PML, that is something that we are working to resolve going forward. So I think it kind of depends.
Did you?
I was just going to say there are a number of what I would call self-management tools out there, which is not a great substitute at all for the kinds of services that people really need. But I'll just mention that there is a caregiver portal that the state has funded. It's called the North Carolina Caregiver Portal that anyone can self-identify as a caregiver and register for. And there are a number of, again, what I would call self-management resources, webinars, videos, resources, support groups, as well as connections to local area agency on aging resources.
I think that's an interesting transition to another question that we got, which is about new types of technologies that can facilitate transitions to home care or home-based care. Can you talk a little bit about those types of new technologies that might be addressing some of the ADLs and IADLs that people need help with?
I can start. One of the things that's exciting about the innovations waiver and even the Medicaid program itself is we can pay for assistive devices, and there's been a lot of advancements in technology. We partner with a provider called Simply Home, and Simply Home offers, and it's something we pay for through the innovations waiver for people. It offers a number of things around, chair lifts and bed lifts, and even things to help make sure that somebody doesn't leave the oven on and start a fire in their home, things like that. So there have been a lot of advances, and the good news is that Medicaid will pay for these types of assistive devices. We also pay for things, we pay for home modifications through the innovations waiver and vehicle adaptations through the innovations waiver. So again, people who are lucky enough to get that innovations waiver slot, it's kind of like a golden ticket. And so we can do things through home modification like ramps, bathroom modifications so that people can get in and out of the shower more easily. So Medicaid, through this waiver program, we are allowed to pay for those types of things to help make it easier for people to live in their home community.
So for our CAP-DA waiver, which is within the next 30 days will be renewed for another 5 years, we have expanded the participant goods and services budget line item to allow for the purchase of assistive devices and assistive technologies. So that's something that we're pleased about. Also, under the 1115 authority, there is the opportunity for more flexibility with spending. So we have, yes, the waivers, but for individuals who are under the 1115 standard plan or tailored plan, there are in lieu of services. And so there's the flexibility to make some limited purchases for services and supports that could include technology.
I forgot to add one thing, and I should have mentioned this earlier. Hopefully everybody in this room is familiar with the Healthy Opportunities pilot that the department is piloting. It covers a number of our counties. We work with Impact Health on that. And so the Healthy Opportunities pilot is also looking at social determinants of health and paying for those non-medical drivers of healthcare to help lower healthcare costs. So some of the things that we're able to pay for with the Healthy Opportunities pilot includes some nutrition support, some housing support, some interpersonal violence support. So there's a number of other opportunities. Now it's a pilot program. It's not available in all 100 counties, but I do want to give a plug for that for the department because it's a first of its kind in the nation program, and it's really we're starting to see some really great data out of it, lowering healthcare costs and giving people other types of supports. Sort of the classic story of the elderly person who goes to the emergency department with heat exhaustion every year when it gets hot in their trailer, and if we would just give them a $200 air conditioning unit, we would save, $20,000, $30,000 a year in emergency department costs annually. So it's some of those types of things that Healthy Opportunities will pay for to help lower healthcare costs.
So just one more plug, because the focus is Medicaid, but clearly there are resources available through the Area Agency on Aging using Older Americans Act dollars. And I think we would be remiss if we did not acknowledge the contribution that those resources make to older adults. And then there is the Family Support 360 program and First in Families that are smaller programs, but for families who have access to those programs, provide meaningful resources to them.
I know we had a lot more audience questions, so maybe folks can seek you all out later during networking times, but thank you so much.